and a lot of molecular studies on that. Everything is coming up in a big way. And residents, I think, should have at least a basic knowledge of this so that they won't feel like they don't know anything once they go to another center. But I think most of the people will be having a little exposure to this, but still there will be few who has not seen much. So I hope this will be helpful. And this is only a basic intro, not a, it's not a complicated session which I'm going to take. It's just a basic WHO classification and on how to approach when we get a pancreato-biliary cytology. I think I will go into the session now. Can you enable screen sharing for me, please?
You can start sharing.
Okay. Is my screen visible, Geetu?
No, not yet.
Okay. Now?
Yes, you can put in slideshow.
Okay.
Okay, now it's visible.
Okay. So let's start with the topic now. When I was practicing, like when I first started practicing the pancreato-biliary system, it was the Papinicola Society cytopathology system which was prevalent. So this system had non-diagnostic, negative for malignancy, atypical, neoplastic, suspicious, and positive for malignancy. This was the category which was used. Actually, this system came about in 2014. And this is how it was classified. So under negative came all the pseudocyst, lymphoepithelial cysts, planules, basic negative ones. And under neoplastic came neoplastic benign, neoplastic other. So under benign came the serous cystadenoma. Under other came IPMN, that is mucinous neoplasms, PANNET and SPEN. Under positive for malignancy came the frankly malignant ones like PDAC, cholangiocarcinoma, acinar cell carcinoma, neuroendocrine carcinoma, pancreatoblastoma, and lymphoma. Now, what is the basic problem with this classification? This has this category, which is the neoplastic benign and other. Now, what is the purpose of any classification system, especially in cytology? So what is the purpose of your Bethesda? Like the cervical cytology, the thyroid cytology, urine cytology. Is it for us pathologists to enjoy the classification? No. It is to assign a risk of malignancy to each category. That means what is the chance that this is a malignancy, definitely a malignancy. And then the next thing is to decide the management of each category. Now, what is the basic problem with the PSC system? This category combines neoplasms with different behaviors under one category. So serous cystadenoma, if you know, it's almost a purely benign neoplasm. Whereas this category, PANNET and SPEN, actually are more malignant. Whereas in these, there are low risk and high risk categories. So if it is low risk, it can be benign. If it is high risk, it can go to malignant. So malignant category. So the basic problem here was that the risk of malignancy and the subsequent management could not be classified correctly. So what happened next is that the IAC, what is IAC? IAC is International Academy of Cytology, approached IARC. IARC is our International Agency for Research on Cancer, and that is the home to WHO classification of tumor. So the IAC approached the IARC and said, let's make a series of WHO reporting system, a complementary series to the WHO histology classification, so that the cytopathology aligns with the histology. And right now, what I'm thinking is why they didn't think about this long time back. Because if you see many of the systems, the alignment between the WHO classification and the cytology classification is not there. So now they have woken up and they have created this aligned system of cytopathology, and this is the screenshot from the WHO Blue Book online. You can see that they have the histology here and cytology here. So it is available. If you buy the online WHO Blue Book, the cytopathology classification is available there. So the first one which came was lung, followed by pancreato-biliary, then lymph nodes, spleen, and thymus. And I think soft tissue will come very soon. So right now, the residents, you should know that in 2022, the IAC, IARC, WHO cytopathology classification is there. So for any subsequent exam which you are going to write, this is the classification you should follow, especially for the lung, pancreato-biliary, and lymph node. For thyroid, you can still use Bethesda. For cervix, still Bethesda. For urine, Parasystem. That has not changed. And so let's see how our new system aligns. So this is the current WHO classification where the epithelial tumors are divided into benign epithelial and malignant. And you can see that the serous neoplasm goes into the benign. The papillary mucinous neoplasms come here. And the malignant consists of pancreatic ductal, acinar, pancreatoblastoma, SPENS. SPEN is solid pseudopapillary neoplasm. I'll be saying SPEN from now onwards so that it's easier for me. And I'll be saying IPMN for intraductal papillary mucinous and MCN for mucinous cystic neoplasm. And anytime if you are not following me, you can interrupt or, you can put in the chat. I may not see, Gidu, if there are many queries, please let me know because I may not be seeing the chat. And pancreatic neuroendocrine neoplasm, as you know, the entire category from grade 1 to grade 3 and neuroendocrine carcinomas are now put under the cancer category, malignant category. So let's see what is the WHO system now. WHO, it's almost the same as the PSC system, just that there is a slight tweaking here. So there is the inadequate, insufficient or non-diagnostic category, benign or negative, where if you see the serous cystadenoma is brought here. Okay, so it was taken from the earlier classification and put here. Atypical, there is a pancreato-biliary neoplasm, low risk, low grade. From now onwards, I'll be saying pan low for this. And this includes low grade MCN, low grade IPMN, and low grade PANIN and BILIN. There is one next classification is pancreato-biliary high grade or pan high, where all the high grade versions of this come. Then there is a species for malignancy and malignant. And you can see that the PANET and SPEN has been put under this category. So this is the importance of the WHO classification, that it aligns more with our present WHO classification. So if you see, this is the PSC system, which I showed first, where under neoplastic benign came the serous cystadenoma, whereas in the WHO system, it is now under the benign or negative category. And under neoplastic other was the PANET and SPEN, which now comes under the WHO. And there is this two new classification instead of the neoplastic benign and neoplastic other. So this is the present classification. And again for the residents, like if you are preparing for the exam, these are the things. See, there is a lot to study in pathology. You cannot study everything. You have to have a focus study. You should have a basic knowledge of everything. And then you should know some things by heart so that you can score in the exam. So these are the charts which will help you score in the exam. So for the risk of malignancy and clinical management, the WHO has again divided pancreas and biliary into two charts. So if you see here, this is the chart for pancreas cytology, and this is the chart for bile duct brushing. Why I'm emphasizing this is, even though the WHO says pancreato-biliary cytology, there is a little difference between. If you see, if there are pathologists here who are seeing pancreas and bile duct on a regular basis, you know that this category is not equal for both, because bile duct brushings in general has a more malignant look to them. And they are many at times difficult to put under definite category, like in case of pancreas. So in pancreas, these are the risks for malignancy and these are the clinical management. When I take the individual subheadings, I will go through it in detail. But as you see here, you can see that the risk of malignancy increases as we go down, and the management also changes. So if it is benign or negative, you only need to correlate clinically. If it is a low risk neoplasm, again only correlate clinically. But once it becomes malignant, the treatment becomes more of surgery, radiation, like that. Now, again, for bile duct brushing, I told you the chart is different. And you can see compared to pancreas, if you see here, if it is negative, it's only 0 to 15% risk of malignancy. But if you see here in the bile duct brushing, there is almost 55% chance of malignancy. Why? Because biliary brushing is very difficult to diagnose on cytology unless you have ancillary testing available. So for your knowledge, most of the cases, almost 90 to 100% of the cases in US and all, now they send for ancillary testing with FISH or NGS for biliary brush, which is not possible even in the place where where I am practicing. Even though we have molecular, we don't send all the biliary brush for that, because uh, it's only on patient to patient basis. They assess whether this patient really needs it. So most of the cases don't go. So unless you are working in a center where everything can be sent for molecular, this will keep on varying. Now, all this is calculated from all the case studies we publish. And most of the case studies will be from places which does not have molecular. Okay. So that's a reason why the risk of malignancy changes so much. And again, one more point which you should know is that this classification does not apply to bile duct brushing. This is mainly for the pancreato-biliary. This, you have to understand that the pan low is, sorry, any pan low features in biliary brush will go to atypical. Any high grade features in biliary brush will go to suspicious for malignancy category. I will say this again and again in case you are having doubt. And then towards the end, if you didn't understand, I will explain it again. So any pan low category will go to atypical. Any features of pan high will go to suspicious of malignancy in case of bile duct brushing. This doesn't apply to bile duct brushing. This is for pancreas. And how should you write a standardized cytopathology report? You should first of all have all the demographic information which is already available to you. But type of specimen is very important. You have to understand that nowadays, most of the sampling from pancreas is by endoscopic ultrasound guided FNA. And most of the biliary tract, it's from brushing. There are also punch biopsies which are not very good. Brushing is more optimal. Clinical and imaging information, I cannot emphasize the importance of this, how much ever I say, because half of your diagnosis, especially in pancreas and biliary, comes from the clinical and imaging information. You cannot make a diagnosis based on cytology alone. Diagnostic summary or conclusion, specimen adequacy, there is no adequacy criteria, if you know. Like in case of thyroid or cervical cytology, there isn't any adequacy criteria for this, but I will tell you what makes something inadequate. Diagnostic category is very important, but don't use the number like we are using Bethesda 1, 2, 3, 4. No, you have to use the terminology. That is whether it is negative, atypical, suspicious, malignancy, like that. Then you have to put a diagnosis. And please understand, especially for the residents, explanatory note or comment. We as pathologists during my residency time was training was mainly to write description. Please understand that description is something which is given least importance by most of the clinicians. What they want and what saves us is usually this note or comment. So one thing you have to train yourself is to write explanatory note or comment for each case. That is to save you, and second is to help the clinician to further manage the patient, because sometimes a clinician won't understand what you mean by a suspicious for malignancy or atypical. They will have to call us and ask, what do you mean by this? What do you want me to do? So it's always good to write a note. This risk of malignancy for this category is this much, and further management suggested is this much. Whether they take it or not is not our problem, but we have to suggest it. Now, before we go into the cytology, the abnormal cytology, we have to know what is normal cytology. Now, are there any queries? at this time? Can I go forward?
Any queries,
Geetu?
audience? You
Okay,
can proceed.
nothing. Anything is there?
No, you can proceed.
Okay, so before we go into the abnormal, let's see what is normal. So this is what normal pancreatic acini looks like on cytology. They are these grape-like clusters. Similar to what we see in salivary gland cytology, we see these clusters of acini, and these are how normal pancreatic acini look like. And these are normal biliary and pancreatic ductal epithelium. This is inspissated bile, and this is a stromal fragment. But these are what ductal epithelium looks like. For me, they always look like our endocervical epithelium on thin prep. And these are very, very important in pancreatic cytology. These are not pancreatic cells. These are duodenal epithelial cells, and these are gastric epithelial cells. Now, why should they come here? Any idea? Any of the residents? Any idea why they should come here? Actually, I'm not able to see the chat. So if nobody is saying, I will say it is the duodenal epithelial cells and gastric epithelial cells come in the when you are doing the aspirate. Because when it's in the head and uncinate process, the duodenum is the root, whereas in the body, the stomach is the root. And so while aspirating, these things come. And please don't confuse this with our normal pancreas. And duodenal epithelial cells have these fried egg appearance because of the goblet cells. That's how you differentiate. But gastric epithelial cells, they are very difficult to differentiate from our normal ductal epithelium, and it's only with experience when you see this apical mucin caps that is more specific for gastric epithelial cells. So let's go to the WHO system, first category, which is inadequate, insufficient, or non-diagnostic. Actually, you can use any of this. We in our department usually use non-diagnostic category because insufficient and inadequate is something which the clinicians doesn't like very much. It's like, oh no, we did such a difficult procedure. We know we went into it. How you can say it is insufficient? So if you say non-diagnostic, it means that, they feel like it's that we cannot diagnose it. We have, pathologist is not able to diagnose it. We have given enough specimen. So we usually use non-diagnostic. And what does it mean? What does this category mean? One that for qualitative or quantitative reason does not permit a diagnosis of targeted lesion. That means there is a lesion there and you have got something, but whatever you have got does not represent the lesion which is present on imaging. So you have to understand, like I told you, there is no specific cellularity requirement for pancreato-biliary cytology. Like in any case of cytology, any ATPA if you see precludes this diagnosis. And use of ancillary test can reduce this category. Repeat FNA or brushing is the management for this category. Now, what are the reasons for this? Suppose there is a preparation artifact like degeneration. You are seeing a lot of blood, contaminant GI epithelium or other material. If you're saying there is a mass, on imaging there is a mass and you have gone into the mass, but you're seeing only normal pancreatic tissue. So even though you have got material, it is not the material which you want. So it becomes again inadequate. So again, there is a solid mass or duct brushing and it is acellular. Then you have a cyst and again, you are not getting anything. But if you get colloid-like mucin, that doesn't make it inadequate. Colloid-like mucin, you are not supposed to see in an aspirate or FNA unless there is a neoplasm in the pancreas. So I'll come to that point again. So this is an inadequate aspirate. Why? In this aspirate, you are seeing only blood, but here there is cell. Then why am I saying that it is inadequate? You're seeing this many cells, and I'm saying it is inadequate. Why? Any idea? Residents, if you participate a little, I think it will be better. Otherwise, this is going to be a very sleepy session. This is, any idea what this is? This is a gastric epithelium, okay? So the gastric epithelium, if you see, it is inadequate. And if you see this, is it adequate or inadequate? On imaging, you are seeing a cystic lesion and you have aspirated and you are seeing this in cytology. Is this an adequate sample or an inadequate sample? There are no cells here. I can assure you, you are not seeing a single viable cell here. Now, is it adequate or inadequate is my question. What is it? Is anyone saying anything? I can't hear.
In the chat box, it is mentioned mucinous.
Mucinous, very good. Geetu, please tell me what is there in the chat box because I'm not able to see it. Okay, so it is not insufficient or inadequate. So if you are seeing mucin, this is the ferning pattern of mucin. It is not inadequate, and I will tell you how to report this and under which category it comes. So let's go into the next category, which is benign or negative. And like I told you before, the serous cystadenoma comes under this category. Now, again, for the residents, this is another important chart which you have to by heart in case of pancreato-biliary cytology. Now, this is a chart which combines both biochemical and molecular. And I think this is more than enough for daily practice and for your exam. This one chart is, very, very important and get you additional marks in case of pancreatic cytology. So the common lesions, especially this is mainly for the cystic lesions, the common lesion which you come across are pseudocyst, serocystic neoplasm, mucinous cystic neoplasms, and IPMN. Now in pseudocyst, one thing you have to know is that amylase will be markedly increased, usually in thousands. It won't be associated with any molecular alteration because basically it's not a neoplasm. Why should it be associated with any molecular changes? Now, these are all neoplasms, so they will be associated with molecular change. Now, in case of serocystic neoplasm, both CA and amylase will not be raised. VEGF can be raised, but it is not usually done routinely. And it can be associated with VHL mutation in a percentage of cases. Now, in mucinous, both mucinous neoplasms, MCN and IPMN, CEA will be elevated. Amylase may or may not be elevated, but CEA has to be elevated. Okay, and both will show KRAS mutation, and IPMN in addition will show GNAS mutation. Please, this chart is very, very important. For pseudocyst, amylase will be markedly elevated. For serocystic neoplasm, both will not be elevated, only VEGF will be elevated. For MCN and IPMN, CEA, they are mucinous neoplasm. Always when you think about mucinous, think CEA, okay, anywhere in the body. So CEA will be elevated, and this may or may not be elevated. Molecular, serocystic neoplasm is usually associated with VHL mutation. Both MCN and IPMN will be associated with KRAS, and GNAS in addition will be mutated in IPMN. So let's go into the benign or negative for malignancy category. Means demonstrates unequivocal benign cytopathological features. That's the meaning of benign or negative for malignancy category, and it includes SEA. And for the risk of malignancy for pancreatic FNA is 0 to 15%. But like I told for bile duct brushing, it can vary widely. It can be 26 to 55%. Management is usually just conservative with clinical correlation. Now, this is a case of serous cystadenoma where you are seeing this benign mucinous, non-mucinous epithelium. Actually, they look like our benign mesothelium, which you see in the peritoneal wash. That's how I remember. It looks actually just like a benign mesothelial lining. But background will show a lot of hemosiderin-laden macrophages. Okay, and this feature can be seen in pseudocyst also, but pseudocyst is a cyst without any lining. So serous cystadenoma will show a lining, and that lining will be seen in your cytology. So again, I'm concentrating more on the epithelium part here. This is why I told you it looks more like your mesothelial lining. So serous cystadenoma, again, I'm telling you the clinical correlation is very, very important. Serous cystadenoma is usually known as a grandmother's tumor. Why? Because it occurs in older females. They are multilobulated and multicystic. Okay, whereas pseudocyst and all lymphoepithelial cyst, all those are all those are usually unilocular, whereas serous adenomas are usually multicystic masses, and the lining is usually non-mucinous epithelium. And background hemosiderin-laden macrophages will be there. Both the CA and amylase will be reduced. It's associated with VHL mutation, like I told you before, and IHC will show strong inhibin and GLUT1 positivity. So these are just the points which you need to know for exam in case of a serous adenoma. So it's known as grandmother's tumor, multicystic, non-mucinous epithelium, hemosiderin-laden macrophages, both CA and amylase low, VHL mutation, inhibin and GLUT1 positive. Now it's for the residents and I need an answer. Suppose this is the aspirate from a 40 to 50-year-old male. There's history of alcohol abuse. There is ill-defined mass. They are suspecting malignancy. And you're seeing these fibrous tissue with few SNI here and there, but basically atrophic and a lot of inflammatory cells. And you're seeing these ductal epithelium, which is, just reactive, not showing many features of malignancy. Background, it's a little dirty, but lot of inflammatory cells. You're seeing little reactive ductal epithelial cells and little reactive SNI. What is your diagnosis? Middle-aged male with history of alcohol abuse. You're seeing slightly reactive ductal epithelium. Acini, but not many, atrophic, background showing inflammatory cells. What is the diagnosis? Fast, please, if you want me to finish this fast. No answer? Geetu?
No answer in the chat box.
So residents are not aware of the clinical history too. I had high hopes for Calicut residents. Okay, so this is a case of chronic pancreatitis. Okay, so that's the importance of clinical history. You are having these trans and little of these reactive changes. So it's often diagnosed clinically. You have an etiology of alcohol obstruction and genetic factors, and there is atrophy of SNR cells. Please do not overcall as adenocarcinoma in this case. That's why I said history, imaging, and serum amylase lipase levels are very, very important in these cases. Again, another case with this. Okay, again a vague mass. There is a history of vague mass and you are seeing a lot of these inflammatory cells. This is a cell block and cell block again showing these fibrous strands. You're not seeing much of ducts or SNI and you're seeing a lot of these lymphocytes and plasma cells. And on imaging, you're seeing this sausage-shaped mass. Any idea what this is? Again, no answer.
Fatima, I would prefer a IgG4 related disease.
Very good. Thank you, sir. I think sir has to answer from now onwards. It's Rajivan, sir, right?
Yes.
Thank you, sir, for answering. Okay, so this is, yes, it's autoimmune pancreatitis. There is a fibroinflammatory process and very, very important here is that it mimics cancer clinically and on imaging. But what is the treatment for autoimmune pancreatitis? It is steroids. Whereas for cancer, the patient has to undergo a very bad procedure. Surgery for pancreas is not a pleasant thing. So this is why importance is there on cytology because many of the times the biopsy in our department especially I've seen that cytology yield more sample than biopsy. Okay, again, this is the cystic mass and you are seeing a lot of these enucleate squames and debris in the background. Imaging, it was a cyst. Any idea what this can be? A cyst with lot of enucleate squames and some debris in the background. If you aspirate it from the skin, what will you give the diagnosis as? Epidermal cyst, right? So in pancreas, what will you give the diagnosis as? Okay, if no answer, I will say. It is a lymphoepithelial cyst, okay? So this is what a lymphoepithelial cyst looks like. And even in histology, it looks the same. You have this squamous lining with lot of these squames and lymphocytes within the wall. So this again, a cystic mass, but no epithelial lining, just looks like a serous cystadenoma with lot of debris in the background and these hemosiderin or debris-laden macrophages. What is the diagnosis for this? You're not seeing any epithelium. And you're seeing this cyst, and by the side you're seeing pancreas with features of chronic damage. So this is a pseudocyst. That's why you are not seeing the lining. Okay, pseudocyst is a very common pancreatic mass, and there will be history of pancreatitis or trauma. Again, I'm emphasizing the amylase will be very, very high. There is no epithelial lining, dirty, proteinaceous or necrotic background, and there will be mostly lymphocytes and histiocytes in the background. So we are going to a slide now. So let's see, what is this? So this is a female, a 60-year-old female with a cystic mass in the pancreas. Okay, CE and amylase is not elevated. You're seeing these lining, and you're seeing this in the background. What is the diagnosis? Any idea what is this? It's okay to be wrong. What is the problem? Whenever I take for residents, I really get some answers. This is the first time I'm not getting any answer from the residents. Why? What is it? I
See,
told
come
you
on.
already.
You can answer anything. No harm in being wrong.
Yes, nobody is going to judge you here or anything. Remove your name from that and answer.
Yes, in the chat box, there are a few comments.
Yes, somebody said serous cystadenoma, and thank you very much for that. Yes, it is a serous cystadenoma. What is the problem in answering? I don't know. Please answer. This is a serous cystadenoma. You are seeing this benign mucinous epithelium and background of hemosiderin-laden macrophages. Okay. So let's go to the next category, which is atypical. Now, atypical is more used in bile duct brushing because bile duct brushing in many cases, especially when there is chronic obstruction with a stone, you have put a biliary stent, everything will show a lot of atypical changes. And many times I've had cases with atypical diagnosis, which has gone into this category later and has gone up to this category also later. So I'm very, very scared of biliary duct brushing. And this is a very common category which we use in bile duct brushing. And you can see the risk of malignancy is huge. And what is the management? Repeat ERCP with cholangioscopy, brushing, and biopsy. In our clinic, in our practice, usually they keep the patient on close follow-up and repeat if they are having any doubt. But usually in US and all, now they are doing ancillary testing with FISH and NGS, which up to an extent can help in putting the patient either this side or this side. So atypical means features predominantly seen in benign lesions and minimal features that may raise the possibility of a malignant lesion. So you cannot put it on either side. You cannot put it on the benign or in the malignant side. Okay, so for pancreatic, it is 30 to 40. For bile duct brushing, it is 25 to 77. And for this is where you prefer to do FISH or NGS. And this is what I'm talking about. This is how you see atypia in brushing. See, suddenly if you see, they look quite malignant, right? But this was a case of obstructive jaundice due to stone. So even in benign cases, bile duct brushing can look very, very malignant. And see, this is a case of adenocarcinoma, where for me, they both look almost similar. This is inflammatory atypia and this is adenocarcinoma. If you see clusters like this, it is very easy. It's almost straightforward, but most of the time it's not like this. For my FRC path exam, the cyto slide, which I had the most problem was a biliary brush. where it was a highly cellular smear with little reactive atypia, which I wrote initially as adenocarcinoma. Then after, at the last minute, I thought it is negative. I cut it and wrote it as negative. Actually, it was negative. And if I had made that mistake, I would have failed in that exam. So that is the importance of this biliary brushing. Very, very difficult to identify. And adenocarcinoma is supposed to show all the features of malignancy in text, but not in real life. Okay. So this is a case which we published from our department, where I had very difficult time with a case where it resembled that of a neuroendocrine tumor. And only after we prepared cell block and did neuroendocrine markers and bile markers, we came to know that it is a cholangiocarcinoma. So let's see one slide now. Okay, so this is a case of bile duct brushing. Okay. Cytoslides are a little difficult to scan if you have seen scan slides, because they have this 3D behavior. It's quite difficult. Anybody wants to suggest what is the diagnosis? If you see like this in a peritoneal or pleural sample, what will you give the diagnosis as? Please answer. It doesn't matter even if you're wrong. I just want the answer. You're seeing these 3D clusters, prominent nucleoli. Normal biliary brushing just looks like normal, endocervical mucinous epithelium. That's what it looks like. And does it look like our normal endocervical epithelium? There is loss of polarity. They are all jumbled up. You're seeing this prominent nucleolus. What would you give this as? Answer, please, fast. Is there anything in the chat box?
Nothing.
Why? Why?
Reactive atypia, one answer is there.
Okay, reactive atypia is a good answer. And for me, if I had got this case, I would have shown it to one more person and would have given as suspicious for malignancy. Yes, it is actually, this case was proved as malignant later on. So this is difficult. It is completely okay to call this as reactive atypia, because even reactive atypia can look like this, but this was a case of adenocarcinoma. So let's go to the next category, which is pancreato-biliary neoplasm, low and high. So our basic thing when we get a cystic lesion is first to determine whether it is mucinous or non-mucinous. Okay, so how do we determine whether it is mucinous or non-mucinous? We have to look at the sample. The mucinous will usually show string sign and they will be very thick. Okay, so that is how we see whether it is mucinous. Then in cytology, we see this colloid like mucin. Once you establish that it is a mucinous cystic neoplasm, the next thing you have to do is to determine whether it is low grade or high grade. And you have to do a biochemical analysis. CEA cutoff is there, which is 192. It has to be above 192. And then if you have the facility, you can do a molecular, KRAS, GNAS, and ring finger to determine whether it is MCN, IPMN, low risk or high risk. So when you get a cystic neoplasm, first thing to determine is whether it is serous or mucinous. Mucinous will be thick, colloid-like material, both on gross and on cytology. The next thing you have to determine is whether it is low risk or high risk. That is low grade or high grade by seeing the cytology. Next, you have to do a biochemical analysis and see whether the CEA is elevated. And then you have to do a molecular. Okay, so this is what I showed you previously. So even if you get only this material, you have to put it under pancreato-biliary neoplasm low risk or low grade. And this is how you write a report. You have to say evaluation limited by scan cellularity. This is a pancreato-biliary neoplasm low risk or low grade. Why? Because you are seeing thick colloid-like extracellular mucin consistent with a neoplastic mucinous cyst. Benign cyst of the pancreas will never show this kind of mucinous material. But you have to always save yourself. putting a note saying no epithelial component is identified, there is no necrosis. Sampling error of cyst lining epithelium may be a limiting factor in accurate risk assessment of the cyst, because who knows that cyst lining may have low grade areas or high grade areas. So this is what a pan low looks like. This is why I said it is very difficult to differentiate it from a normal gastric epithelium. It looks almost like a normal gastric epithelium. But the low risk or low grade group will have low grade nucleus. The nucleus will be very benign looking. And this is not established for, like I told you, this category doesn't apply for bile duct brushing. And these are the risk of malignancy, and management for low risk is usually very conservative. Okay, so this was a case which we received in our department. So this was a mucinous cyst, a tail of pancreas with spleen case. And this was a degenerative change actually after aspiration. It was filled with this hemorrhagic material when I received it. There was a fibrous, thick-walled cyst in the tail of pancreas. And this was the epithelial lining. Is there, okay. So this was the lining. If you see, there's the remnant of pancreas, a very fibrous cyst wall lined by this mucinous epithelium. There was no high grade features anywhere, very low grade looking. And these are the remnants of pancreatic epithelium. And this is the ovarian type epithelium beneath it. So the lining you can see was very benign looking. And this was the aspirate of this case, where you are seeing this mucinous epithelium, low-grade appearing mucinous epithelium with thick colloid-like mucin. And so that is pan low. Okay, now I'm coming to pan high, where you can see in addition some degree of necrosis. Why? Because it is going more towards malignancy. And you can see these clusters of high-grade looking cells. And again in this, you can do molecular, which can help, like TP53 mutations, MAD4 deletion, P16 deletion. IHC can also be done on the cell block. And if you detect any of this, it can help in putting towards the high risk category. The risk of malignancy is 60 to 95%, and surgery should be done. Whereas in case of pan low, you can even adopt a conservative approach. Now, it is very challenging to definitely distinguish between whether it is IPMN, IOPN, ITPN, MCN and all. You are not expected to do any of that in cytology. In cytology, you can just call pancreato-biliary neoplasm and grade the atypia. You need not differentiate the subcategories. Okay, you just can put it under pancreato-biliary neoplasm. Now, this is another case. So this was a 40-year-old female with pancreatic cyst fluid. If you can see, the CEA is highly elevated. Okay, so there is a cyst and highly elevated CEA. And this is the slide. So you know it is a mucinous cyst with high CEA. So it has to be MCN or IPMN. And you are seeing these cells. How will you put the diagnosis? Are these okay looking cells? Are they low grade or are they high grade? Anyone please? Are these low grade cells or high grade cells? So you have a cyst in the pancreas, high CEA. You know it is a mucinous cyst, and on aspirate you are seeing these cells. Are they low grade or high grade?
Answer is one. Answer is high grade and another is low grade in the chat box.
No, low grade usually have very scant cellularity. Okay, high grade has this kind of cellularity and these high grade looking nucleus. One thing you have to know is that I think this is a thin prep. Oh no, it is I think smeared only. In PAP, the nuclear features may not be as severe as you see in GIMSA. So this is a neoplastic mucinous cyst with high-grade area, and this was the corresponding histopathology. I just showed you a low-grade mucinous cyst, my case, where there was just a fibrous wall with one layer of lining. And look at this. Within the lining, you are seeing these invasive nest. This is the meaning of a mucinous cyst with an invasive neoplasm. Invasive neoplasm arising in a mucinous. So this would have had a high-grade dysplasia and later developed a malignancy in the wall. So the diagnosis in this case was neoplastic mucinous cyst, invasive adenocarcinoma arising in a mucinous cystic neoplasm. Okay. So this is the importance of cytology. It can help the clinician in deciding the further management. Next, we'll go to suspicious for malignancy category, where you know there are features of it is going to be malignant, but you cannot say for sure that this is malignant. That is when you put suspicious for malignancy. And in case of pancreas, it's 80 to 100% and 74 to 100% risk of malignancy. Management, you have to, if the patient can undergo surgery, if the patient is fit for surgery, you have to do surgery for this patient. But if the patient is not fit and you are thinking about neoadjuvant therapy, you have to do a repeat FNA. That is the management option for this case. So when will you say suspicious for malignancy? You are getting an aspirate, you are having only few cells, but the cells are all like this. There is some degree of atypia, there is loss of polarity. This was actually a case of pancreatic ductal adenocarcinoma, that is PDAC, which was later proven, but the cellularity was very less. Again, you are getting an aspirate like this, only this cluster of cells are there, and you are seeing these kind of abnormal looking SNI. This came out to be SNR cell carcinoma later on. So it is when the cellularity is very less, or you don't have enough material to do a cell block later on, then you give it as suspicious for malignancy. And even in biliary brushing, you can give suspicious for malignancy in many cases, like the slide which I showed you just now, where you know it is, it is going to be malignant, but you are still not sure whether it is reactive atypia. You can give it as suspicious for malignancy, but in this case, ideal thing is to do an ancillary testing. So let's go to the next and one of the most important category, malignant. This is what the residents need for most of the exams. And this demonstrates unequivocal cytopathological features of malignancy, and management is according to the clinical stage. So let's go one by one. Please, I want the answers fast if possible. So this is pancreatic ductal epithelium. But where is the honeycomb pattern? Honeycomb is all abnormal. And this is called drunken honeycomb pattern. The honeycomb is all drunk and in different ways, seeing this side and that. And you are seeing these kind of high-grade atypia in the nucleus. And here also, if you see, this is called washed out nucleus. And there is lot of atypia here. But it is hypochromatic, not hyperchromatic, but still it is abnormal. It is abnormally hypochromatic, okay? And there is a mass. And it's an older male or female. What is the diagnosis? Fast. It's pancreatic ducts, which is not in a proper honeycomb, and you are seeing lot of atypia. So what is the most probable diagnosis? Fast, please. When you see ductal epithelium, pancreas mass is there. You are aspirating ductal epithelium with lot of atypia and a drunken honeycomb pattern. What is the diagnosis? And I'm telling you it is malignant.
One answer is mucinous cyst adenocarcinoma.
It is pancreatic ductal adenocarcinoma. Okay. Mucinous cyst carcinoma will have a cyst. Now I'm telling you it's a solid mass in the pancreas. Solid mass is usually pancreatic ductal adenocarcinoma. If it is a mucinous neoplasm, there is usually an associated cyst with it. But don't, it's not like recently we had a case of pancreatic ductal adenocarcinoma which had undergone degeneration, tumor-related degeneration, which can also look like a cyst. But MCN usually have a cyst on imaging and mucinous fluid in the background, which is not seen here. Okay, so often locally advanced or metastatic at diagnosis and unresectable forms an irregular solid mass. That's why I said the clinical and imaging is very important. Pleomorphic nucleus, drunken honeycomb pattern is very important, and biopsy and IHC will help you P53, SMAD4 and even P16. What happens in SMAD4 and P16? Deletion. So loss will be there and P53 will be abnormal. So either null type or diffuse. So this is how a PDAC looks like. I've stopped asking. Okay, now I'm telling you, this is what PDAC looks like. So this is what is known as drunken honeycomb. The slides which I showed you didn't depict it properly. That's why I'm showing you this slide. So you can see that this is duct epithelium, but it's kind of in a wavy pattern. It's not normal. And you are seeing a lot of this nuclear ATP. See, in most, that is another problem for us. Well-differentiated pancreatic ductal adenocarcinoma may not even show much of a nuclear atypia. But this high cellularity and drunken honeycomb pattern is a very, very important feature in cytology. So this is what is meant by drunken honeycomb pattern, and this was a case of pancreatic ductal adenocarcinoma. So let's go to the next slide. Okay. Now, what I'm going to tell is that for the residents, please, the solid masses which doesn't show ductal epithelium and show these kind of monotonous appearing blue cells. There are 4 DDs. Okay. So one is neuroendocrine tumors. Second is acinar cell carcinoma. Third is solid pseudopapillary tumor. And fourth is pancreatoblastoma. Pancreatoblastoma is usually not kept in exams. The other 3 are kept. Which are they? Acinar cell carcinoma, neuroendocrine tumors, and solid pseudopapillary tumors. Acinar cell carcinomas usually will have, I'm not saying in clinical practice, but for exams, if they keep, they usually have an acinar pattern. Okay, they will be like normal acini, but little more cellular and little more nuclear atypia, and they will show some degree of prominent nucleoli. For neuroendocrine tumors, usually the nucleus will have neuroendocrine features, which is a kind of plasmacytoid appearance and salt and pepper chromatin. Solid pseudopapillary neoplasm, just like in histo, it will show papillae lined by these monotonous cells. The problem is, yes. So the problem is that in all this, the cells look kind of monotonous. So I am going to show you one of these 3. It is either acinar, neuroendocrine, or solid pseudopapillary neoplasm. Let's see if you can diagnose. So this is a solid mass in the pancreas, and this is the cytology. Okay. This is another cytology, and this is another cytology. Can you diagnose this? Is it acinar? Is it neuroendocrine, or is it a solid pseudopapillary neoplasm? Can anyone make a guess? Is it acinar cell tumor? Is it neuroendocrine tumor, or is it a pseudopapillary tumor? According to what I told you.
Acinar cell carcinoma.
Very good. It's acinar cell. Why? Can you explain too?
Prominent nuclei and acinar pattern.
Very good. See, this is acinar pattern. And you are seeing, see, prominent nucleoli, if you get it, well and good. But many cases it may not show, but if it is there, it's a very good indicator. Okay. And these are all acini, but very hypercellular, and there is nuclear atypia. So it's acinar cell carcinoma. So it's malignant pancreatic epithelial neoplasm with acinar cell differentiation, classically older men. So clinical correlation is important. Lipase hypersecretion syndromes will be associated. And you see these hypercellular smears with 3D fragments, acinar architecture, large nuclei with prominent nucleoli. You can see a granular cytoplasm. That also you can look in the background, the granular background. Now, IHC is one thing which you have to write in your exams, and even in clinical practice, they will be usually positive for trypsin, chymotrypsin, and BCL10, whereas for NETs, neuroendocrine marker will be positive. For SPEN, beta-catenin will be positive, and KI will be around 10 to 50%. But this IHC is important: trypsin, chymotrypsin, BCL10. Okay, now anyone can tell me what is this? Actually, it looks almost similar to the previous, except for few features which is seen here.
Neuroendocrine.
Very good. What are the features which you are seeing here?
Plasma, like eccentrically located nucleus.
Yes.
Plasmacyte nucleus and salt and pepper chromatin.
Yes, very good, excellent. Okay, so this is well-differentiated neuroendocrine tumor, and they're usually slow-growing tumors, can be functional or non-functional. Loosely cohesive cells, stipple salt and pepper chromatin, synaptochroma will be positive. You can grade in cyto. I have had clinicians asking me to grade in cyto, but it is very difficult. You can do in cell block, but even now the accepted criteria is to do it in histo, and that too in a hotspot. Okay, but you can attempt in case the clinician asks. Okay, now what is this? These are all classic cases which you may or may not get in exam, real life actually. But this is a classic appearance. Tell me what is this? Anyone,
Span.
please?
Span.
Yes. Span, very good. It is span. You are seeing this papillae lined by monomorphic cells. What is this immuno? What immuno is this?
Beta-catenin. Beta-catenin.
Very good. Very good. This is beta-catenin. So it's a low-grade malignant pancreatic tumor composed of poorly cohesive cells forming solid and pseudopapillary structures. Again, history. Young women, body or tail. Okay. And you see these neoplastic cells cling to branching papillary fronts with central vessels, monomorphic nucleus, and nuclear beta-catenin, which is usually only one immuno is usually enough for this. CD99, PR, CD10, Ki is usually low. But one thing is, if you don't see the papillae, you may mistake it for neuroendocrine tumors, and it can express in some cases neuroendocrine tumors. That's why we say whenever we get these monomorphic appearing cells on pancreatic aspirate, it's better to do a panel of immuno. So next quiz. Let's see who says the diagnosis first. What is the diagnosis in this case? It's a 39-year-old female with a tumor. What is it? It's very straightforward, right? If you get it in a thyroid, what will you call it? A 39-year-old female with a mass in the pancreas. Tell me, what is the diagnosis? Monomorphic cells, papillae. These are papillae lined by monomorphic cells. No one knows the diagnosis? It's a very classic appearance. One which I've already told you now, just now. Yeah, it is a SPEN. These are monomorphic cells, and you're seeing all these vascular structures. Okay, that's why I said if I show you a picture, it is easier. But when you get a slide, it's a little difficult. You may get confused. Is it a neuroendocrine? Is it an SNR cell? See, you're seeing these papillae. And I think they have done a beta-catenin. See how beautiful it is, the beta-catenin. Okay. One more. Yeah, we are finishing fast, don't worry. We'll finish in 5 minutes. Okay, let's see. Again, a solid mass. Little elderly person. What is the diagnosis? Any idea? Diagnosis, please. You are seeing these vague acini. You are seeing prominent nucleolus. What is the diagnosis?
Acinar
Acinar cell carcinoma, yes. But now you understand why I said these are differentials. Never for exam write straightforward acinar cell carcinoma and stop at that. Right? my DD for this will be this, and I will do immuno to differentiate it from the other two. So never give a confident diagnosis because these four are differential. Fourth one is pancreatoblastoma, which is not very common. So again, for revision, this is the biochemical and this is the molecular. I'm not repeating it again, just I will say the important ones. Amylase in pseudocyst, VEGF in serocystic neoplasm, CEA in MCN and IPMN. So what are the ancillary testing? You should do a cyst fluid analysis. So ideally, if you get a cyst fluid from a pancreatic neoplasm, you're supposed to triage it into three. One should be sent for biochemical analysis, one for molecular analysis, and the remaining should be centrifuge, and the sediment should be made into cytology. So when you send for biochemical, you should check for CEA. Cutoff is 192. Amylase cutoff is 250. So less than 250 will essentially rule out pseudocyst. So if the clinician is suspecting pseudocyst and the amylase is less than 250, no, it is not a pseudocyst. Molecular profiling. So what all are the molecular things you will do? Like I told you, KRAS, abnormal in both MCN and IPMN, GNAS, supports IPMN, P53, SMAD4, P16 in high risk and also in PDAC. Again, all these in high risk. VHL in serous MEN1 in neuroendocrine tumors, CTNNB1 in SPEN, PRKACA in IOPN, oncocytic pancreatic neoplasm. And FISH, just one slide on it. What does FISH look for? FISH is mainly done to look for aneuploidy deletions and amplifications and frequently performed on bile duct brushing of strictures, especially useful if inflamed. That is what I was telling you about. And nowadays, most of the high-end centers have Eurovision FISH already. If you know, Eurovision FISH is something which is used to detect urothelial carcinoma. And Eurovision FISH has probes for CDKN2A, 3, 7, and 17, which can be abnormal in our high-grade neoplasms also. That is pancreato-biliary. So most of the centers currently use the Eurovision FISH for pancreas too, but pancreatic-specific probe kits are coming now from the studies which are going on. So I think this WHO classification again will get updated very soon once the molecular studies come up again. So these, I'm not a part of these studies, but it was done in our center, endoscopic ultrasound guided FNA of pancreatic adenocarcinomas and grading of pancreatic adenocarcinomas. These were studies done in our center on pancreas. Now this again is a quiz question, and with this we will come to an end of our session. So this is again in a 70-year-old male patient with pancreatic mass, and this was the aspirate. So this is the cytology and this is the cell block. What is your diagnosis? You can have a wild guess. You can say anything you want. Just imagine if you get an aspirate like this anywhere in the body, what will your differentials be? Can anyone make a guess on what this can be? This is a pancreatic mass, aspirate, and this is a cytology, and this is the cell block. Now, if you can try on your own to describe this cytology, and then you will get the diagnosis. How will you describe each cell? And then you have your diagnosis. What is the cytoplasm like here? How will you describe the cytoplasm? And how will you describe the nucleus? Cytoplasm is clear, right? And this is central nucleus. And this is cell block. Suppose it's not pancreas. It's from anywhere. Suppose it's from the liver. What will your first DD be? Or is it from, if it is from a skin nodule? Or is it from brain? No diagnosis, or from lung? Anywhere in the body. It's for residence. It's one of the very common exam cases kept. No idea. At least one person. Give a wild guess. What can this be? Okay, now just not even one person can make a diagnosis. Okay, any of the staff can also make the diagnosis.
There is a common metastasis from squamous cell carcinoma.
Yes, very good. It is metastasis, but not squamous. Squamous will have dense keratin, right? You're not seeing keratinized type of cytoplasm, but I'm happy that somebody thought about metastasis. So what can it be? Clear cytoplasm, central nucleus. Just look at the morphology here in the cell block. What's the
HCC.
Other comment HCC and RCC. Two comments.
Very good. So this is an RCC mets. Okay, so don't think that malignancies of pancreas can only be primary. It can be secondary too. Now, this also looks like an RCC mets, right? But this was a case from one of the hospitals here, the previous place where I worked, okay? And this is a foamy gland variant of pancreatic ductal adenocarcinoma, okay? So see how it can resemble each other. So this is a foamy gland variant, which is not very common, but can be seen. Okay, so again, the importance of doing immuno. You have Paxate and CK7 can help. Paxate will be positive, as you know, in this one, and CK7 will be negative in RCC. Okay, so even metastasis can occur in the pancreas, so don't just think of primaries. Okay, I think we have come to an end of the session. Any doubts are there, means you can ask.
Any queries from the audience?
Want to comment, anyone? Anyone?
All are tired, ready to run off, I think.
No, they are stuck. Thank you very much, Fatima. Anyway, it was so educative, so descriptive, and from the point of view of an exam going candidate, it's a very,
Yes,
very
sir.
useful. I think you should be more presenting more often.
Okay, so anytime.
And
Okay.
not so frequently described kind of stuff also. This is only very
Yes,
rare described.
even for me, it's all new. Even
Very
I'm in the process of learning, actually.
highly useful for the PGs.
Yes.
Thank you very much.
Thank you, sir. Thank you for the opportunity. Shall I leave now then?
Of course.
Geetu? Yeah. Thank you.
Thank
Thank
you.
you.
If you are interested, you can watch. Wait.
Shall we move to case presentations now?
Yes.
So the first case is from MES Medical College. Dr. Mohsina will be presenting the case.
Good morning. Good afternoon. Ma'am, I'll share the.
Yes, you can share.
Is it visible?
Yes, can you please turn into slideshow mode?
It's visible, right, ma'am?
Yes, it is visible, but not in the slideshow mode.
Um,
Yes, now it's visible.
So good afternoon all. Today, I'm going to present two cases of ANA negative lupus nephritis that we got in our center. So first was a case of 14-year-old male who presented to the pediatric OPD with facial puffiness since 4 days, headache and vomiting since 1 day, and he had a history of sore throat and fever 1 week back. On examination, he had pedal edema and facial puffiness, his BP was 160/100 mmHg. And in urine, albumin was 4+, and urine protein was 1962. Urine creatinine was normal range, and urine PCR was 17.67. His serum protein was low, and his serum C3 was also low. Then he was evaluated for ANA, and in that, anti-dsDNA and ANA profile was negative. And they had a clinical diagnosis of infection-related glomerulonephritis. And they received renal biopsy specimen, and it showed, the section showed 15 renal tissue showing 15 glomeruli, and all the glomerulus were showing increased cellularity with mesangial cell proliferation and endocapillary cell proliferation. And here you can see neutrophils as well. This is the images of various glomeruli showing increased cellularity, and there was mild tubular atrophy, and in trichrome stain there was mild interstitial fibrosis. And it was histomorphologically it is a diffuse proliferative glomerulonephritis, and DDs were lupus nephritis, IRGN, and IgA nephropathy. So in immunofluorescence, it showed IgG 3+ granular, IgA 2+, and IgM was negative. C3 was 3+ granular, C1q was patchy 3+, and kappa and lambda was 3+ granular. And we gave the final diagnosis, lupus nephritis class 4, with an activity index of 5 and a chronicity index of 2. In this, since ANA was negative, we gave the diagnosis as ANA negative lupus nephritis. And we send the specimen for electron microscopy also for confirmation. And we could see subepithelial deposits, electron dense subepithelial deposits. Here, subendothelial deposits was also present, and mesangial deposits were present. And also, there were tubular reticular bodies. And tubular reticular bodies are usually seen in electron microscopy within the cytoplasm of endothelial cells, and it is seen in autoimmune diseases, very specific for autoimmune diseases and viral diseases, and almost always seen in the tissues of patients with HIV, and also in sarcomas like Kaposi sarcoma. And this was the EM report that we received with the diagnosis of diffuse proliferative lupus nephritis class 4. So coming to the discussion, lupus nephritis is seen in 50% of SLE patients, and they present with hypertension, pedal edema, hematuria, and proteinuria. And it is actually due to the immune complex deposition within the glomerulus. And the lupus nephritis has been divided into 6 classes. In this, we have to know about the ANA negative lupus nephritis, which is 8% of the lupus nephritis cases. And in that, only 1.5% of those patients show positivity for cytoplasmic and mitotic cell patterns. Remaining 6.5% are negative for nuclear staining or any cytoplasmic and mitotic cell patterns, which is called the anticellular negative lupus nephritis. And in immunofluorescence, we can see full house immunofluorescence, which is granular. And there are minority of cases due to tubulointerstitial or vascular disease. And there is a non-lupus nephritis where we can see a renal disease without any immune deposits. And there is another set of cases with silent lupus nephritis where there is no clinical evidence of renal disease, but in glomerulus, there can be immune deposits and pathological abnormalities. So coming to the 2019 ULAR ACLR classification, which gives the entry criterion of anti-nuclear antibodies or any equivalent positive test should be positive, then only the entry we can go into the additive criteria. But in our case, even when the entry criteria is not met, looking into the additive criteria, we get a total score of 19, depending on the clinical and immunological domains. In clinical domains, we had the patient had fever, proteinuria, and a renal biopsy class 4. And immunologically, there was a low C3. So these patients, even if they are ANA negative initially, they develop ANA positivity in later stages with a gap of few months to 10 years. And the actual phenomenon for this is not clear. In 2012, there was a criteria given, that is the SLIC, Systemic Lupus International Collaborating Clinics classification criteria, in which they said at least 4 criteria should be met, with at least 1 clinical criteria and criterion and 1 immunological criterion, or if the sole clinical criterion lupus nephritis is met with the presence of ANA or anti-dsDNA antibodies, then it qualifies the criteria. In our case, there was renal involvement clinically, and immunologically, there was low complement. But in lupus nephritis, in centers like MES, we usually go into the immunofluorescence and the electron microscopy. Here we can see there is whole house immunofluorescence staining with intense C1q staining. Then in electron microscopy, there is extraglomerular deposits with combined subepithelial and endothelial deposits and tubulo-reticular inclusions. This was another case that we received in medicine department with that was a case of 46-year-old female with no known comorbidities who presented with anemia and thrombocytopenia, and her serum creatinine was 1.5 initially, which increased to 5.4 in 10 days. Urine PCR was 14.9, serum C3 was low, and Holmes test was negative, and ANA-IFA also was negative. Here, we received renal biopsy, and it showed 5 glomerulus, all showing increased cellularity with increased mesangial cell proliferation and endocapillary cell proliferation, and neutrophils are also seen within the glomerulus. And there is moderate interstitial inflammation composed of lymphocytes, plasma cells, and few neutrophils. And in trichome, there was moderate mild to moderate interstitial fibrosis. And in immunofluorescence, similarly, there was IgG was 3+, IgA was 2+, IgM was negative, C3 was 3+, C1q was 3+, kappa and lambda was similarly 3+, and we gave the final diagnosis as lupus nephritis, class 4, diffuse proliferative lupus nephritis with an activity index of 5 and chronicity index of 2. And we also sent it for electron microscopy, and here they had plenty of subendothelial and few mesangial and rare subepithelial electron dense deposits, even though the final impression was not given as lupus nephritis. So here the take-home message is that lupus nephritis can be diagnosed even if the ANA is not negative, depending upon the SLIC criteria, and if ULR criteria is taken into consideration, then the entry criterion should be ANA positivity. But here, in such cases, even if the equivalent test ANA serology comes positivity in later stages of the patient presentation. Thank you.
Thank you, Dr. Mohsina. Now the case is open for discussion.
Good afternoon.
Good afternoon, ma'am.
That was a good presentation. But
Thank
actually, I'm Dr. Bindu from Calicut Medical College. See, sometimes we get full house positivity in some infection related and other immune complex mediated also, isn't it? But
Yes.
in SLIC criteria, you said C1q, it should be strongly positive. In the first case, you showed G was positive, but C1q showed only 1+ and patchy positivity, segmental only, isn't it?
Yes, ma'am.
So can we just classify it as full house nephropathy, which without this other ANA and anti-DS DNA, can we ideally classify it as, call it lupus nephritis? As per the SLIC criteria also, you said there should be some organ damage, isn't it?
Yes, ma'am.
Will you just show that criteria in the SLIC criteria? Can you show the slide?
Okay.
If ANA and anti-DS DNA both are negative, what is the marker for lupus?
Anti-Smith can be done.
Yeah, Smith antigen. And was it done?
No, ma'am, it was not done.
Tubular-reticular inclusions are also not specific for lupus, isn't it?
Yes.
Could be any. It
Yeah.
can be in HIV also. So
This is
previous slide before this. Okay.
this one.
Yes. With at least one clinical criterion and one immunological criterion. What immunological criterion was positive? Was there?
Ma'am?
What was the immunological criterion present?
There was a low C3, ma'am.
Oh. C3 can be low in any immune complex mediated disease, isn't it? IgA.
Yes, ma'am. But the full house immunofluorescence and
Full house also you can get.
in complement.
Q was not very brightly positive, strong positive.
Actually, it was patchy, but it was 3+.
Didn't look 3+.
Yeah.
Okay. I thought it is better to give us full house nephropathy and follow up the patient. Sometimes the patient may develop SLE. Only a small percentage develops SLE in such cases.
Okay, ma'am.
See the C1Q? Not that much bright, isn't it? And patchy also.
Yes, it is patchy.
Did the patient receive any treatment earlier? Some immunotherapy?
No, no treatment given, ma'am. They treated as lupus nephritis itself, and now the patient is well. But we don't know more about the patient. We contacted the nephrology department, but we didn't get much of the follow-up.
Okay.
They said the patient responded.
Okay.
See, one Dr. Feroz here. One of the diagnosis.
Sir, you are not audible.
Certainly is IRGN in this. Even clinically also they said it could be IRGN. We found
Sir, your voice is breaking. Sir, it is not audible.
Feroz, is it audible to you? വരുന്നുണ്ടല്ലോ. No, there is a communication problem.
yeah. Can you hear now?
Yes, sir. Now it's
Yeah. What I quickly try to say that what I was saying is one of the differential diagnoses certainly in histopathology or histology also is IRGN. Clinically also they considered the possibility of IRGN. The reason why we came to this conclusion is the location, site of deposition. Usually in IRGN, you get the deposit in the subepithelial region. Here we had massive subendothelial and mesangial in addition to subepithelial also, which is quite unusual in IRGN. And since you have a renal SLE also, a single organ involvement of SLE, we thought we should go by this SLE. The SLE criteria certainly meets in this case. And even the ULAR, if you remove the entry point of ANA, the other criteria is meeting for SLE. So in consultation with the clinicians, we thought we should go ahead with starting the treatment of SLE in this skill, not to withhold the treatment of SLE because he made SDNA later.
so you are not audible.
No, is Feroz trying to say something more?
No. I think that was my point basically. In consultation with the clinicians, in view of the deposits in all three locations, which is very unlikely in IRGN, we thought the treatment of SLE should be started in this patient. not to withhold that, because maybe after 6 months or so, you may become ANA positive as well. So this is how the decision was taken.
Okay. The patient didn't have a pre-existing SLE or known case. It's not a known case.
No, the ANA was not positive. dsDNA also was negative in this, which is explained in the literature that a case like this can develop dsDNA later on. One of the reasons they say the serological negative may be due to excretion of the immunoglobulins through the kidney, so that only kidney SLE will be seen, not the serology. That is one of the explanations they give for a negative ANA in lupus nephritis.
Right. Okay, that's it.
Any
Shall
more
we-
queries?
No, nothing more. You can proceed with the next case.
Okay, the second case is from Malabar Medical College. Dr. Dhanya Ashokan, junior resident, will be presenting the case. Dr. Mohsina, can you stop sharing, please?
Good afternoon. Today we are presenting a case of 30-year-old female who was presented with multiple episodes of vomiting and a recurrent history of loose stools for the past 3 months. She had a history of weight loss over the same duration, no history of fever, pain, abdomen, and blood in stools. Under general physical examination, the patient was apparently within normal limits, and under systemic examination, her abdomen was soft with mild diffuse tenderness, and other systemic examination were within normal limits. These were the investigations done. CBC was showing total leukocyte count of range 10,000, and differential count was showing mild neutrophilia. Then stool occult blood was done. It was negative. And we done serology for HIV, HCV, and HBsAg, which was non-reactive. Since the patient was suspecting as a case of Crohn's disease or inflammatory bowel disease, D1 biopsy was taken on February of 2025 from outside, and it was suggestive of chronic duodenitis with cryptitis and crypt abscess. After 1 month of treatment, the patient was not feeling well. Her symptoms were not subsided. So right colon biopsy was taken on March 2025. It was also taken from outside, and it was suggestive of mild non-specific inflammatory infiltrate. And she came to our hospital on April, and we done OGD scopy, which was showing mild antral gastritis and mild duodenitis. Based on clinical evaluation for infectious or inflammatory disease, D2 biopsy was taken. So grossly, we received multiple bits of pale white soft tissue. And under microscopy, this is the scanner view showing duodenal mucosa as fragments. And here we can see blunting and broadening of villi, as well as we can see expansion of lamina propria. Coming to high power view, we can see dense inflammatory infiltrate in lamina propria composed of lymphocytes and plasma cells, and occasionally very few neutrophils and eosinophils. Here we can see increased intraepithelial lymphocytes also. Coming to same magnification, we can see some round to oval structures. Those are resembling to denudated epithelial cells, which are seen free floating within the lumen of duodenum. When this section was viewed under oil immersion, it was found that these are some pear-shaped organisms which were arranged in falling leaf pattern in the lumen of duodenum. Even though there is no any specific special stain to identify this organism, we did methylene blue and the organisms were stained, and here it is very clear these organisms can be seen as pear-shaped in the lumen of duodenum. We also done Giemsa stain, which stained positive for the organism. Here it is very clear these organisms are arranged in falling leaf pattern. So to summarize, a 30-year-old female presented with complaints of multiple episodes of vomiting and loose stools, accompanied by significant weight loss over a period of 3 months. In presence of this organism, we had called her to know about travel history, and it is found that she was residing at Punjab for last 1 year. And duodenal biopsy findings were showing blunting and broadening of villi with increased intraepithelial lymphocytes and dense inflammatory infiltrate in lamina propria composed of lymphocytes and plasma cells. And in addition, we could find pear-shaped organisms morphologically resembling with Giardia lamblia within the lumen of intestine arranged in falling leaf pattern. So we finally came to the diagnosis of giardiasis. It is confirmed by histopathological identification of Giardia species in duodenal biopsy and with associated features of chronic duodenitis. We also advise the patient to do stool examination. So coming to discussion part, Giardia lamblia is a protozoa belonging to Mastigophora, and it's mainly habited in our duodenum and upper part of small intestine. So it is common intestinal pathogen which is seen in patients with common variable immunodeficiency, and it often leads to chronic or recurrent gastrointestinal symptom. One finding which we can see in CVID patients is absence of plasma cells within the lamina propria, but in our case, lamina propria was infiltrated with lymphocytes as well as plasma cells. And talking about the morphology of organism, they exist in 2 forms, trophozoite form and cyst form. So this is the life cycle of this organism. A person acquires infection by ingestion of food and water contaminated by the cyst form of this parasite, and it reaches the small intestine where it undergoes excistation to release 2 trophozoids. These trophozoids within the intestinal lumen undergo asexual reproduction by binary fission to produce more trophozoid form and results in clinical manifestation. After that, some of the trophozoid goes to the colon where it undergoes encystation to form cyst form. This cyst form will be released through fecal matter, and it contaminates water and food. If a person takes this food and water contaminated by cyst form, he also acquires the infection. So the mode of infection is by ingestion of food and water contaminated by cyst form of this parasite. So laboratory diagnosis of Giardia lamblia, As we discussed, intestinal biopsy, in intestinal biopsy, we can see this organisms as pear-shaped and in falling leaf pattern within the lumen of duodenum. And we also discussed that blunting and broadening of villi with dense inflammatory infiltrate in lamina propria and intraepithelial lymphocytes is other finding. Next, we can do weekly trichome stain in stool. Here the organism is stained positive. Next, we can demonstrate cyst microscopically in stool, and tropozoites can be identified in duodenal aspirates. Then we have immunological techniques like enzyme-linked immunosorbent assay, and Giardia-specific antigens can be detected using enzyme immunoassays. So our possible differential diagnosis in the absence of this organism could be celiac disease, tropical sprue, and HIV enteropathy. In all these disease, we can see the same findings which we discussed, that is blunting and broadening of villi with dense inflammatory infiltrate in lamina propria, composed of lymphoplasmacytosis, as well as increased intraepithelial lymphocytes. The only difference is the absence of this organism. So coming to the treatment, we can treat the patient with metronidazole, tinidazole, and these are effective therapeutic agents. And finally, prevention. We should ensure a safe water supply through boiling or by chemically disinfecting, and also monitor and prevent any fecal contamination of water. Thank you.
Thank you, Dr. Danya. Any queries? If there are no questions, we will move to the final case. Dr. Ashwati Raj from Government Medical College, Kozhikode will be presenting the case.
Good afternoon. Myself, Dr. Ashwati Raj from Government Medical College, Kozhikode, presenting a case of a 20-year-old female who is a college student, presented with complaints of fatigue for 10 days duration, history of nasal discharge and dry cough present for 3 days prior to the onset of fatigue, no other symptoms present. Clinical examination. General examination shows pallor, no lymphadenopathy, vitals were normal, systemic examinations were within normal limits. Investigations, hemoglobin was reduced. It was 6.5 gram per deciliter. Platelet count also markedly reduced, 18,000 per millimeter cube. Total count and RBC indices were within normal range. Total bilirubin and indirect bilirubin was slightly elevated. Liver enzymes, RFT, that is urea and creatinine, within normal range. Peripheral smear of the patient was sent. Peripheral smear shows anisopoikilocytosis. RBCs were normocytic normochromic with marked polychromasia, and occasional spirocytes were seen. And WBC count was normal and shows thrombocytopenia. So the final peripheral smear report given as spirocytic hemolytic blood picture. So following the peripheral smear report, patient was further evaluated for hemolysis. So the reticulocyte count was elevated. It was 10%. Serum haptoglobin is low. Serum LDH was also markedly elevated, 1367 international unit per liter. Direct Coombs test and indirect Coombs test were negative, and USG abdomen shows no splenomegaly. So it's a young female who presented with anemia and thrombocytopenia, and peripheral smear shows features of spirocytic hemolytic anemia. And blood investigation also favors a hemolytic blood picture. So the clinician initially considered an immune-mediated hemolytic anemia. Since the direct Coombs test and indirect Coombs test were negative, he considered and Coombs negative autoimmune hemolytic anemia. It is rare condition. It is seen in 5 to 10% of cases. It is either due to low affinity antibodies or antibodies other than IgG, which binds to the RBC membrane, mostly IgA antibodies, or IgG antibodies which binds on the surface of RBC are too low, which cannot be detected by standard Coombs test. So they also rule out other autoimmune causes. Since it's a young female, they also rule out other autoimmune causes of hemolytic anemia. They sent ANA profile and APLA profile, which comes negative. And also urine hemosiderin was done, which was also negative. So with the diagnosis of hemolytic anemia, they have started methylprednisolone pulse therapy for 3 days, which is followed by oral steroids, and they evaluated the hemoglobin and platelet count of the patient. But the platelet count and hemoglobin was progressively declining, and there was no improvement seen with steroid therapy. So they reconsider the diagnosis because most of the autoimmune hemolytic anemias will improve on steroid therapy. So they also work up for any hematological malignancy. They did bone marrow study because patient had bicytopenia. So bone marrow imprint shows mild erythroid hyperplasia. Along with bone marrow, they also sent a repeat peripheral smear, and the repeat peripheral smear shows anisopoikilocytosis and marked fragmented RBCs, which is seen 5 to 6 per oil field. And along with fragmented RBCs, polychromasia is also seen. Schistocytes were seen predominantly. Along with schistocytes, few microspirocytes are also seen, and few normoblasts are seen, and also had thrombocytopenia. So the peripheral smear report given as impression microangiopathic hemolytic anemia. So this is a case of microangiopathic hemolytic anemia with thrombocytopenia, that is thrombotic microangiopathic hemolytic anemia. So these were the differentials we can consider: thrombotic thrombocytopenic purpura, Shiga toxin associated hemolytic uremic syndrome, drug-induced thrombotic microangiopathy, infections, malignancy, malignant hypertension, and disseminated intravascular coagulation. Since our patient doesn't give a history of loose stools and the RFT of the patient was normal, they ruled out the possibility of Shiga toxin associated hemolytic uremic syndrome. And there was no history of drugs which cause drug intake, that is the drug causing thrombotic microangiopathic hemolytic anemia like ticlodipin, quinine, and anti-cancer drug like mitomycin C. That possibility was also ruled out. And there was no clinical signs and symptoms of infection or malignancy. That also ruled out. And the patient doesn't have a previous recorded evidence of hypertension and during the hospital stay also the patient blood pressure was normal and there was no bleeding manifestations or evidence of sepsis. Malignant hypertension and DIC was also ruled out. So considering after ruling out all the possibilities of thrombotic microangiopathic hemolysis, they concluded a possibility of thrombotic thrombocytopenic purpura. To assess the risk of severe ADMTS 13 deficiency, the clinician do a scoring system called plasmic score. Plasmic score is a clinical scoring system that predicts the likelihood of ADMTS 13 deficiency that will help to initiate plasma exchange therapy. This scoring system was developed by two doctors called Dr. Pavan and Dr. Robert of Harvard Medical School. It has high sensitivity for TTP. And this is used by clinician in patients who have thrombocytopenia and microangiopathic hemolytic anemia. So this template is available in online. It consists of 7 parameters, include platelet count less than 30,000, hemolysis, active cancer, history of solid organ or stem cell transplant, MCV less than 90 femtoliter, INR less than 1.5, creatinine less than 2 milligram per deciliter. For each score, we give a score. For each parameters, we give a score of 1, and we add all the scores together to get the final score. And if the final score is more than 5, it indicates that there is a high risk of severe ADMTS13 deficiency and patient needs plasma exchange therapy. So this is the scoring system. If the score is 0 to 4, patient belongs to low risk group and 0% risk of severe ADMTS 13 deficiency. And if the score is 5, belongs to intermediate risk and there is 6% risk of ADMTS 13. And 6 to 7, it is high risk group and 72% risk of ADMTS 13 deficiency. So our patient belongs to 72% risk of ADMTS 13 deficiency. So considering the possibility of thrombotic thrombocytopenic purpura and the high plasmic score, patient was shifted to ICU and samples were sent for ADMTS 13 level before starting plasma exchange, and patient was initiated on plasma exchange therapy. During the ICU stay, patient developed headache and hallucinations, which later improved on plasma exchange therapy. The response to plasma exchange, patient hemoglobin and platelets started improving after giving plasma exchange therapy. After giving 3 days of plasma exchange, started rituximab, which is an immunosuppressive agent, and later on the plasma exchange is continued till the patient platelet count becomes normal. In the meantime, we also received the report of ADMTS 13 assay, which shows marked ADMTS 13 factor level, which is decrease in ADMTS 13 factor level less than 10%. Also, there is high level of ADMTS 13 inhibitor, that is 82.234 international unit per milliliter. So it suggests a diagnosis of immune-mediated thrombotic thrombocytopenic purpura. So the final diagnosis given as thrombotic thrombocytopenic purpura due to severe ADMTS 13 activity deficiency due to ADMTS 13 inhibitor. Coming to discussion, TTP is a type of microangiopathic hemolytic anemia. It is characterized by pentad of symptoms like fever, thrombocytopenia, hemolytic anemia, renal dysfunction, neurologic dysfunction. It can present as dyad or triad of symptoms. In our patient, she has thrombocytopenia, hemolytic anemia, and later on she developed neurologic symptoms. Atypical TTP is TTP present with acute stroke or transient ischemic attack. There is no microangiopathic hemolysis and thrombocytopenia at the time of initial presentation. TTP results from decrease or absence of the enzyme ADMTS13. It's a disintegrin and metalloproteinase with thrombospondin type 1 motif member 13. It's a von Willebrand factor cleaving protease and is synthesized primarily in the stellate cells of the liver. Coming to the pathophysiology of TTP, von Willebrand factor is a plasma glycoprotein which is derived from vascular endothelial cells. It supports platelet adhesion and aggregation at the site of endothelial injury. It is synthesized as a disulfide bonded polymer, and the ADMTS13 will convert von Willebrand factor polymer into multimers by repetitive cleavage at tyrosine 1605 methionine 1606 bond. It can be either due to congenital or acquired ADMTS13 deficiency. In congenital, there will be decreased production of the enzyme, and in acquired, there will be enzyme will be normal. There will be inhibitors that will inhibit the action of the enzyme. TTP is defined by severely deficient activity of the ADMTS13 protease to less than 10%. So this is the diagrammatic representation. So von Willebrand factor in normal circulation, it's seen as a closed configuration. When there is microvascular stenosis and high shear stress, this will undergo configurational change and expose the platelet binding domain, that is A1 domain in the von Willebrand factor. That leads to binding of platelet to the von Willebrand factor and causes platelet aggregation and thrombosis. But if ADMTS13 is present, it will bind to the A2 domain and cleave the tyrosine methionine bond. So in the deficiency of ADMTS13, there will be uncontrolled von Willebrand factor and platelet aggregation, which leads to thrombosis. So in case of severe ADMTS13 deficiency, that is less than 10%, there will be increased von Willebrand factor multimers that leads to unregulated platelet adhesion and aggregation, which causes disseminated microthrombi and organ ischemia. Because of microthrombi, the RBCs get trapped and causes lysis of the RBC or fragmentation of the RBC, forming schistocytes. And because of the consumption of the platelet causes thrombocytopenia. There is hereditary and acquired TTP. Hereditary TTP is due to mutation of ADMTS13 gene, which is located on chromosome 9q34, which is also called Shulman-Opshaw syndrome. It is rare, seen in less than 5% of cases and present during neonatal period. Acute TTP is more common, which is seen in more than 95% of cases, and due to autoimmune inhibitors that will act against ADMTS13 protease. ADMTS13 inhibitors are primarily IgG antibodies. IgA and IgM can also seen. It usually seen in adolescents and adults, and the median age is 30 to 40 years. The investigation, we can do CBC, which shows anemia and thrombocytopenia. Peripheral smear shows hemolysis, schistocytes, and thrombocytopenia. Serum haptoglobin will be decreased or undetected. Reticulocyte will be elevated. Serum LDH will also elevated. RFT will be normal or minimally deranged. CT or MRI done to look for neurologic dysfunction. Other tests we can do is ADMTS13 activity level. TTP patient have severe deficiency. This test is based on the degradation of either full-length von Willebrand factor or synthetic peptides of von Willebrand factor by ADMTS13 in the plasma. So these cleavage products are detected by ELISA, mass spectrometry or electrophoresis. Then ADMTS13 inhibitors. The inhibitor test measure the ability of antibodies to block ADMTS13 activity. This is measured by mixing patient and normal plasma samples, and this ADMTS13 activity is significantly reduced if inhibitor is present in patient's plasma. Next is ADMTS13 antibody assay. It measures the presence and quantity of any antibody against ADMTS13 done by ELISA, and this is more sensitive test compared to inhibitor assay. Coming to management, we can do plasma exchange. Therapeutic plasma exchange with fresh frozen plasma is the frontline therapy for thrombotic thrombocytopenic purpura. This will supply adequate level of ADMTS13 and remove circulating anti-ADMTS13 autoantibodies. Plasma infusion is used as an emergent substitute until plasma exchange. Next is immunosuppression. The general principle of therapy is to target antibody production. Therapy is typically started concurrently with plasma exchange. The drugs commonly used are glucocorticoids and rituximab. Next is anti-von Willebrand factor. This include caplacizumab and N-acetylcysteine. Caplacizumab is a humanized immunoglobulin targeting the A1 domain of von Willebrand factor. This will prevent the interaction with platelet. N-acetylcysteine will degrade the ultra-large von Willebrand factor multimers and inhibit von Willebrand factor dependent platelet aggregation. Newer drug is recombinant ADMTS13, which is under phase 3 clinical trial, which can be used for hereditary TTP. Coming to follow-up, the patient was symptomatically better at the time of discharge. Unfortunately, we lost the follow-up of the patient. take-home message. TTP is a life-threatening illness which requires prompt recognition and management given its high mortality if left untreated. Acute management and long-term follow-up is required. These are my references. Thank you.
Thank you, Dr. Ashwati. Any questions?
You showed the peripheral smear on 2 occasions, no? In the first occasion, were there no schistocytes?
Sir, after the repeat peripheral smear, we again reviewed the first.
Then only you detected them.
Sir, initially it was not seen. After this repeat peripheral smear, we again reviewed the first peripheral smear. There were few fragmented RBCs were there, but mainly spirocytes and polychromatophils were there. In the first.
So schistocytes were not evident in the first one.
It was not evident.
Hemolytic anemia thrombocytopenia combination is not common. So one is TTP, then you can get an Evans syndrome.
No, they also
associated
suspected
with
Evans syndrome.
malignancies. So you have to think of those things in such line, in that line, because that also avoids the unnecessary Coombs test. If you detect the schistocytes early, a Coombs test may not be necessary. Anyone else? Anything more to be asked? Already ചോദിച്ചാണല്ലോ. Gitu, is it over?
Yes, sir. If there are no more queries, we can wind up the session. The next session
All very
will
much.
be
Thank you.
after 2 months in June.
Hopefully after 2 months.
Okay, thank you, everyone.
Hello.